Sirs, bonjour.
Bonjour. Hello. Kalimera.
Great to have you. All these problems with the internet.
Yeah, I'm really sorry. I don't understand because the test was fine, but I think that my laptop crashed down.
Okay. I think the problem is solved, and we're very happy to have you with us and to share your thoughts with us. Okay. So.
Yes, thank you. I'm sorry for all the inconvenience. Sorry.
Michael, θες να το παρουσιάσεις?
Good morning, Professor Boveda. He's a well-known electrophysiologist from France, head of the arrhythmia unit in Toulouse, and he is going to give us a lecture about the persistent atrial fibrillation and cryo technology use. Please.
Hello, my dear friends, my dear colleagues, Kalimera to everybody. Hello from Toulouse, southwest of France. I'm really sorry not to share this great meeting with you. I would be much more happy to be there. But, you know, we are living difficult times, and in addition, my internet is also very, very difficult to manage right now. So finally, we could solve the problem. So I'm speaking with you through my iPhone, and I will try to share this presentation with you. Thank you again to Professor Βασιλικός. Thank you to the organizers for inviting me to share our experience about cryoblation in persistent atrial fibrillation. So next slide, please. So these are my disclosures. Next slide, please. So as you all know, in the latest weeks, maybe 3 weeks ago, we had the new guidelines from the ESC, and in these guidelines, it's clearly stated that you need to perform a complete electrical isolation of the pulmonary veins in all AFib ablation procedures. That means not only for the paroxysmal AFib, but also for the persistent atrial fibrillation ablation. And this is a class 1 recommendation, so this is something that is no discussion. Next slide, please. So you can do that, of course, with the point-by-point ablation, with new features like the contact force catheter, with even the high energy. But I don't see the slides. Could you please display the slides for me? Is it possible? Because I don't see the slides anymore. Could you display the slides, please? Do you see the slides? I don't see the slides anymore.
We're trying to solve it out, says.
Okay. So as I was saying, you can perform the pulmonary vein isolation thanks to the 3D mapping system with a point-by-point radiofrequency ablation with the new features like the contact force catheter. Thank you. I can see it now. And the high energy, of course, this is working very well. But as you can see, it's a very tricky procedure because you need to do a complete isolation of the veins, and you need to avoid absolutely any gap between the points of radiofrequency. And this is not something that is easy to do at the first time. So you need a lot of experience, a lot of skills to do that. Next slide, please. Okay, so the title of the presentation was, this is a time for chill. And time for chill means, of course, next slide. Means, of course, relaxing, and it means also freezing. And the perfect tool for these two points, the relaxing and freezing, is, next slide, the cryo balloon. Next, please. the cryoballoon ablation catheter. So here you can see an example of cryoblation in which we use a big cryoballoon, 28 millimeter balloon with an achieved catheter, which is just placed at the distal part of the balloon in order to assess the PV potentials. And we are using, in this case, in our center, Professor Βασιλικός, I think, saw that when you make us the honor to visit us in France. We are using a fusion system between the CT scan and the fluoro system. And this is very helpful because it's giving you the landmarks, the anatomical landmarks of the left atrium, namely the left appendage, the pulmonary veins, the ostium of the pulmonary veins, and you can assess at real time where you are placed with the balloon. The balloon has the big advantage to allow a single shot disconnection of the pulmonary veins. I have lost again the slides. I don't know if it's possible to display the slides again, please. And if you can see in this case, the balloon is inflated at the antrum of the right superior pulmonary vein, if I remember well on the slide, because I don't see the slide anymore, but I'm sure it was the right superior pulmonary vein. And you can assess at real time the positioning of this balloon in a very safe and secure fashion, because you can really assess the anatomy thanks to this fusion. And this is, I think, something that is really helpful for the learning curve, especially for the young doctors, the young EPs that you want to train for AFib ablation, because, yes, next, please. Okay, because they can see exactly where they are, and they have an anatomical reference of the procedure. Next slide, please. You can assess also very easily at real time the disconnection of the pulmonary vein. In this case, so this patient was a paroxysmal, but it's the same in persistent AFib. You can exactly see at what time you are disconnecting the the pulmonary vein by assessing the PV potentials. Next, you can see here that there is a slight prolongation of the distance between the left atrial far field and the PV potential. And finally, at the right side of the slide, you can see the disappearing of the PV potential. And that means between these two beats, the last one and the previous one, you have at that time the disconnection of the vein. So it's very easy to see at what time you can obtain a disconnection of the vein. And this is helpful to assess the time to isolation. And this is very important. Next slide. You can also assess the exit conduction by pacing thanks to the achieved catheter at the proximal part of the pulmonary vein. And in this case, you can see the spike potentials that are slightly faster than the spontaneous sinus rhythm. And you can see the P wave, I would say the fourth complex. You can see that there is a modification of the morphology of the P wave because you are capturing the left atrium from the pulmonary vein. And you can freeze at the same time. And you can see this is a continuous tracing below the panel B. You can see that the third complex, the second arrow, you can see that you have a loss of capture between the spike potential, the pacing, and the capture of the left atrium. You can say that between this spike and the previous one, you have an exit block. So real-time assessment of entrance block and real-time assessment of exit block. This is very easy to do. This is very visual, and I think that this is very helpful. Next slide, please. The Frankfurt team, Funkranz, about 10 years ago, already showed that you can disconnect with a single shot more than 80% of the pulmonary veins. And I can say that today, thanks to the time to isolation, we can disconnect nearly 100% of the pulmonary veins with one single shot. And this is, in my opinion, the only tool that allows a single shot disconnection of the pulmonary veins. Next slide. But it's not only PV isolation, it's more than that. You are also ablating because you are very antral with a balloon, with a big balloon, 28 millimeters. I remember you, it's a big balloon. You are also ablating fragmented potentials. You are ablating the ganglia. You are ablating substrate, rotors, etc. So it's not only PV isolation. And you can see it very well when you are doing a high density voltage map, like in the next slide, please. So big balloon at the antrum of the vein. Next slide, please. Thank you. You can see here in a high density voltage map that was performed in a patient that had a previous ablation by radiofrequency about 6 months ago. You can see that there is a clear reconnection, at least of the left inferior pulmonary vein, but certainly also of the right superior. And we perform a cryoballoon ablation in this patient. And you can see very well that with the voltage map after cryoablation, the surface of the scar, the surface of the fibrotic tissue due to the ablation is much wider than after the first radiofrequency ablation that was maybe performed a little bit too distal, not too antral. And you can see in the posterior wall with the balloon, you can obtain a treatment of the substrate of about 2/3 of the posterior wall. This is the right color, so this means that this is the scar, and this is again the treatment that you can obtain with a cryoballoon, big cryoballoon. Next slide, please. So we have done a trial with the cryoballoon in the persistent atrial fibrillation patients. We were at that time, it was about 5 or 6 years ago. The paper has been published 2 years ago in 2018. 5 French groups, 4 or 5 German groups, 1 group from Greece, our friend George Andriokopoulos. And in this paper, we have shown something that was a little bit surprising, is that in the persistent AFib patients, when you are performing PV isolation only, it's true, but with a cryoballoon, you can perform the procedure in less than 1 hour. Next, please. You can see on the right panel at the bottom that it's about 55 minutes mean procedure time for persistent AFib, which is not the case when you are doing, of course, a much more complex procedure with a substrate treatment. But in this case, with a PV isolation only with a cryo, in less than 1 hour, you can obtain a treatment of the patients. The result and the success rate, next slide, was not extremely good. It was about 61% at 1 year, 61% of sinus rhythm at 1 year. Of course, it's not excellent, but it's very consistent with other papers. But it's only a PV isolation, only cryoballoon with a single procedure, and in 6% more or less of patients, we had to maintain the antiarrhythmic drugs. But that means that you have also, next slide, you have also 40% of failure, which is, of course, not satisfactory. So we need something else, for sure. There is no question about that. And you all know about the STAR-F2 paper in 2015 by Verma that showed that if you are adding substrate ablation, so fragmented potential ablation or lines, you don't have an advantage when you're comparing to PV isolation alone. And the success rate in this paper was also next 60%, like what we had with a cryoablation, with a single PV isolation, with a cryo balloon only in less than 1 hour, I remember you. Same success rate. Next slide. But you can also do substrate ablation with a cryo, and we have more and more papers now, and we are this experience in Toulouse since many years also, that you can perform, for example, a roof line with a balloon. And the advantage of the balloon is that it's very stable, and the line is not a thin line, it's really a very large line that you can perform on the roof. And in this paper, which was a propensity score of patients treated by radiofrequency and patients treated by cryo, more or less 100 patients in each group, about 40%, if I remember well, of the patients had an additional line on the roof. So it was PV isolation for all patients, 100% of the patients, and roof line about 40% of the patients in both groups, RF and cryo. Next slide. You can see that the global success for both groups, cryo and radiofrequency, it's the left side of the slide. It's not significantly different between both energies, between radiofrequency and cryo. It's about 60% at 3 years this time, both with cryo and radiofrequency. Remember, 40% of the patients add an additional line on the roof in both groups. But if you are going to the right side of the slide, you can see next that you have a very significant difference between the cryo group and the radiofrequency group in favor of the cryo. You are considering the patients that had an additional roof line. So that means the 40% of patients in both groups that were treated with an additional line on the roof, you can see that in this case, the cryo does better than the radiofrequency. Maybe it's because the roof line with the cryo is more efficient because it's wider, it's with less risk of gaps than in the radiofrequency group. And this is, I believe, very interesting. Next slide. But you can also do other kind of substrate ablation with the balloon. In this case, we are doing a substrate ablation of the left appendage. And it's very easy to do with the balloon. Very easy, but it can be risky. I don't say that it's something that you have to do systematically, of course, but in some very selected cases, it can be helpful. And next slide, sorry. In this paper, the experience of this team that made again a propensity score between two groups, a group of PV isolation only, and a group of PV isolation plus left appendage ablation with cryo balloon. You can see, next slide, that when you are considering the group with a PV isolation plus the left appendage ablation, left appendage disconnection, you have a much better success rate at 1 year. Again, you can observe that the success rate of the PVI only is about 60%. Another time, remember 60% in cryo for persistent that we did with George Andriokopoulos, 60% in STAR-F2, 60% of the papers of the Brussels team, 60% in Frankfurt, also for persistent, 60% here again with PV isolation only, but when you are adding something else, you are improving the success rate very significantly in this case. Next slide. And I will finish with a last thing that you can also perform. Much more difficult, I have to tell you, but it's the posterior wall isolation with a cryo balloon. This is the team of Arash Ariana from Sacramento, who is performing, you can see on the left panel of this slide, a very complex setting of cryo balloon applications all around the posterior wall. in order to disconnect completely the posterior wall. But this is really not easy to do. Again, I have to tell you, we have made many patients, and this is of course another time something that you cannot propose systematically. There is no proof of that, and it's very complicated to perform this kind of procedure. And in addition, next slide, you can see that in 30% in the red square, you can see that in 30% of the patients, you have to add radiofrequency points in order to completely disconnect the posterior wall. Next, you can see that in this case, you have a small gap in the most posterior line of the posterior wall, below the line below, and you can see that at this spot you really need to perform additional points of radiofrequency, because this spot is very difficult to reach with a cryo balloon. So again, it's not something that is easy, but it's under research right now. So it's interesting to have these numbers, and the results are interesting. See next slide, please. You can see that when you are considering the PV isolation only, or you are comparing with the PV isolation plus posterior wall isolation, you are improving again very significantly the success rate of the patients at 1 year, around 60% again with PV isolation only, and around 80% with a PV isolation plus posterior wall isolation. So in conclusion, my dear friends, next slide. No, sorry, there is still one. Sorry. Next slide, please. Yes, I would like to remind, and I think that is very important, that in the latest guidelines a few weeks ago, again, from the ESC, this kind of ablation, extra PV ablation, so lesions on top on PV isolation, that means fragmented potential ablation, left appendage disconnection, roof line, anything, the posterior wall isolation is a class 2B indication in the ESC guidelines. That means that there is, and this is very important, not something that you should perform in a vast group of patients. There is no proof of that, but this is something under investigation, and maybe in the future we will have some indication for which patients it can be interesting. So this is my conclusion now, my friends. Next slide. So the cryoballoon ablation is nowadays a reasonable, effective, and safe option for the first ablation procedure of persistent atrial fibrillation with a high rate of durable PV isolation with wide antral lesions. So not only PV isolation, but more than that. It's a fast procedure with low fluoro times. And you can also, in some selected cases, some selected patients, propose an additional left atrial substrate modification besides PV isolation, and extrapulmonary vein ablations are possible and feasible in this case. But this is, again, under further investigation and not something that you should do systematically. Thank you very much, my friends.
Thank you, Professor Boveda, for this nice speech. Do you have time for questions? Professor Vasilios?
Serge, thank you very much. Very, very nice talk. And I was wondering, since I've seen the electroanatomic maps after cryoablation, or we call it like, everything is distracted. And when we have redo cases, we do it with CARTO, and we are impressed what's the extension of low voltage areas. Have you seen any left atrial dysfunction after the cryoablation on these patients?
No,
there's debate about this, but with cryo?
Yes. To be honest with you, I think that no. First, we never had seen that, never. But I think that the good thing, the nice thing with the cryo is that is not distracting not distracting the architecture of the left atrium. Is only, let's say, it's only providing an inactivation of the cells. It's not distracting the structure of the left atrium. I think that, and if you are speaking with people like my friend Carlo Dasmundis from Brussels, he is very investigating these points, and his opinion is that the cryo is not touching the lower layers of the myocardial wall, and I think that at least cryo is not an energy that is more destroying than radiofrequency. Maybe it's the opposite. Of course, this needs to be proven, but we don't have this experience that we in these big disconnections of the posterior wall, and so of course, if you are disconnecting completely the posterior wall, it can be that the left atrial function is not as good. But if the patient is in a fib, it's not good at all. So I think that this is an important point that is important to discuss. I agree. We don't have at the present time a clear answer to that. But what I believe is that it's not more destroying than radiofrequency energy. This is my opinion.
That's my feeling as well, because already these patients with persistent AF, already they have atrial dysfunction with fibrosis or whatever you want to say. And probably it's better to restore sinus rhythm on these patients anyway. Michali, you want to say?
Can I, one question. I think that for paroxysmal atrial fibrillation, cryoblation is an excellent tool. It's easy and fast. In persistent atrial fibrillation, I have a concern about other atrial tachycardias that coexist with persistent atrial fibrillation. I mean that we know in paroxysmal atrial fibrillation, atrial flutter coexists in about 30% of patients with paroxysmal atrial fibrillation. So in persistent atrial fibrillation, you are ready to ablate also, not only atrial fibrillation, but right atrial flutter or atrial tachycardias from the left atrium. So this is, for me, the main disadvantage of using cryoblation for persistent atrial fibrillation. This is one disadvantage for using this technology. So maybe I want your comment for this. Maybe it is more logical to use cryoblation for persistent atrial fibrillation, thinking concerning that this is the first procedure and the patient knows that probably he will come again to the lab for a second procedure for arrhythmias like right atrial flutter or atrial tachycardias. Is this correct or it's not?
Yes, absolutely. I think that you did a very, very good point here, and I completely agree with you. But it's not so simple. Let's say, I will try to summarize. If you have a patient in which you know already that you have something else than AFib, you shouldn't use cryo first. I think that in a patient that you have an additional flutter or atrial tachycardia, I will not go for cryo first. I would go for radiofrequency. I fully agree on that. The difficulty is in the patients that have only atrial fibrillation, not any other arrhythmia. In this case, with the results of cryo for persistent, for example, and other trials, the stop persistent AF that has been also presented in the ESC, it has exactly, in HRS too, it has exactly the same results, more or less. In this case, in these patients, you know that if you're proposing cryo first, you may have more than 50% of the patients in which you will have a success rate. It's not excellent, again, I'm not saying that this is the solution, this is not the universal solution, but it's not so bad, and at least it's more or less the same success rate that you can expect with other more complicated techniques, more longer, and maybe with a more risk. So the real question here is to know before ablating which patients would be sensible to the cryoablation. And this is a question that today doesn't have a clear answer. In our center, we are proposing cryo first in patients with have a normal left atrium, not too much dilated, quite recent persistent AFib, less than 1 year, better less than 6 months. I think that in these patients, you have more chances to have a good efficacy of the cryoablation. In a patient with a very wide dilated left atrium, with a very long persistent, long-lasting AFib, the cryo with PV isolation only will not be certainly a good solution for them. But we still need to detect those patients in which the pulmonary veins will be the solution and patients it will be not enough. And this is something that this is my dream. I would like to have an answer here to give you to say, in this patient, just do the PV isolation with a cryo. It's less than 1 hour, it's very safe, and it's very efficient. That would be great. But at the present time, we don't have a good way to select those patients. So what we are doing is trying to take clinical features, as I was saying, normal left atrium, recent persistent AFib, no valvular disease, and in these patients, we are proposing a first cryoablation procedure, saying them that maybe it will be needed to do a second one with radiofrequency this time, because of course, if you have a left atrial attack or something like that, we'll use radiofrequency for the second procedure. But they are already aware of that, and I think that is fair to propose them a simple solution, saying that they have 60% of chances of being cured from the disease and 40% to have a second procedure. I think that it's fair.
Okay.
Yeah. Any other questions? Yes. Final question from Professor Frankakis.
Very, very much for your excellent talk. My question is, as you move to the posterior wall with cryo, do you think that there is more concern about potential complications like esophagus damage? This is one question. Second, the balloon is made mainly for PVs. It's anatomically well designed to fit in posterior wall, and in that case, how you check the isolation posterior wall once you have applied the energy? Thank you.
Very nice questions again. Thank you very much. First, for the esophagus, sure, you are 100%. There is a concern for esophagus when you are targeting not only the posterior wall, but also the roof only. And in this case, we are using always a probe in the esophagus to measure the temperature at the real time. So, of course, it's very important to be aware of this risk. And in these patients that we are going for extra PV ablation with cryo, but also, of course, with radiofrequency, we are placing a probe to measure the real-time temperature in the esophagus during the procedure. And if we have a temperature of less than 16 degrees Celsius, then we stop the cryo because we think that it could be a risk for the esophagus. So this is the first question. For the second question, to assess a complete disconnection, okay, first of the roof, because it's important, it's quite easy to do. We are placing the achieved catheter in the left appendage in order to pace in the anterior part of the left atrium, and we are assessing the conduction in the posterior wall with a 4-pole catheter that is placed in the posterior wall. We are measuring the distance between both, and we are assessing the direction of the activation in the posterior wall. If we are going from below to up, that means that it's blocked in the roof. If we are going from up to below, it's not blocked. So it's quite easy to do with a little bit experience. For the posterior wall isolation, in all patients, we need to do what I showed you before, a high density voltage map of the posterior wall in order to assess the remaining gaps. And as I told you, in my experience, more than 30% of these patients, there is a gap. So it's absolutely necessary to make a kind of hybrid approach of cryo plus RF in these patients. But again, it's a to be indication in the ESC guidelines. It's something that is not routine. It's something that is in very selected patients and necessarily never in first intention. So again, I think that is very special, and it's not something I would like to give the impression to you that is something that we are doing on routine basis every day. It's not the case. It's not true. So again, but I think that it's an exploratory way, and it's interesting. It's like a hybrid approach with surgery, etc., etc.
Okay, thank you very much, Serge. Thank you for sharing your experience with us. It was a great time for us to be with you, and we hope next year to be in person. So take care, and thank you very much, and see you again, okay?
Thank you a lot, and sorry for the inconvenience with the connection. I'm really sorry, but thank you again for the invitation.
At the end, everything worked very well. Thank you.
And you can be sure that next year I will be with you.
Okay, without a mask.
Okay, okay, sure. Bye-bye. Have a nice meeting. Thanks again.
Thank you.
Bye-bye. Thank you.
Ευχαριστώ πολύ όλους σας. Πήγαμε λίγο πίσω, αλλά νομίζω άξιζε τον κόπο. Θα προχωρήσουμε στο επόμενο session που έχει σχέση με την καρδιολογία και την ψηφιακή τεχνολογία. Ο κύριος Λεκάκης και ο κύριος Τσιούφης είναι online. Ο κύριος Λεκάκης...
Ναι, είμαι, κύριε Βασιλικέ.
Καλημέρα.
Γεια σας. Τώρα βλέπω και τον κύριο